We're going to start off talking about guys and prostate cancer. So, prostate cancer is a tumor of the prostate gland, and we know that it's the most common cancer among men, excluding skin cancer. It's the second leading cause of cancer death in men, and it's succeeded only by lung cancer. We know there's a higher incidence in African American men, but it's lowest in Asian men. Prostate cancer is a slow growing androgen dependent cancer, and it can spread by three routes: by direct extension, through the lymph system, or through the bloodstream. Because it's so slow growing, some men elect not to treat it and simply die with prostate cancer, but not actually from it. So, prostate cancer typically has no symptoms in the early stages, and eventually the patient may have LUTs, similar to those of BPH. If there's metastasis, they might have some lumbosacral area pain that radiates down to the hips or legs, and some combined urinary symptoms as well. Neither PSA nor DRE, digital rectal exam, is a definitive diagnostic test for prostate cancer. If PSA levels are continually high or if the DRE is abnormal, a biopsy of the prostate tissue is usually done. Guys, a biopsy of prostate tissue is necessary to confirm the diagnosis of prostate cancer. Low-grade prostate cancer is relatively slow growing. Therefore, a conservative approach to management of prostate cancer is active surveillance or watchful waiting. With active surveillance, patients are typically followed with frequent PSA measurements and DRE to monitor the progress of the disease. There's also surgical approaches for prostate cancer. A radical prostatectomy is where the entire prostate gland, including the seminal vesicles and part of the bladder neck, are removed. Post-op, they're going to have a large catheter with 30 cc balloon in place that's also going to help apply pressure to help reduce the bleeding. However, two major adverse outcomes after a radical prostatectomy are erectile dysfunction and urinary incontinence. There's also something called bilateral orchiectomy, which is the surgical removal of the testes. It's going to result in total androgen deprivation and prostate shrinkage. However, it's rarely done because how many men want to walk around with no testes, right? So it creates a lot of body image issues. We always, of course, have to be concerned with post-op infection because of where the incision is. It's a very dirty place, right? So you want to make sure you keep it clean, as clean as possible. Brachytherapy, guys, is interesting. It's these seeds that have radioactive matter inside of them, and then they implant them into the prostate gland. Some of the side effects for that, though, is erectile dysfunction and urinary dysfunction as well. Androgen deprivation therapy is going to be therapy where we take away the androgen completely, so it's going to further slow the growth of the cancer. However, the problem is that the tumor can become resistant to the drugs that take away the androgen. Bladder cancer. Bladder cancer is the most common cancer of the urinary system. About half of bladder cancers are related to cigarette smoking. So if you smoke, I recommend you start putting it out. Other risk factors are going to include exposure to dyes used in the rubber and other industries. Another risk factor include women who are treated with radiation for cervical cancer, believe it or not. So patients who received cyclophosphamide, docetaxel, or gemcitabine, and those who have indwelling catheters for long periods are at risk for bladder cancer. People with chronic recurrent urinary tract stones, often in the bladder, and chronic lower UTIs have an increased risk for squamous cell cancer of the bladder. Microscopic or gross painless hematuria is the most common manifestation of bladder cancer. Bladder irritability irritability with dysuria, frequency, and urgency may occur. Bladder cancers can be detected using CT, ultrasound, or MRI. However, the presence of cancer is going to be confirmed by cystoscopy and biopsy. Treatment is going to vary depending on grade, stage, and multicentricity of the tumor. There's going to be surgical therapies that can be used for bladder cancer, but there's different types. So the first one that we're going to talk about is a transurethral resection of the bladder tumor, and it's used for superficial lesions of the bladder's inner lining. A segmental cystectomy is used to treat larger tumors, or those that involved only one area of the bladder. When the tumor is invasive or involves the trigone, by the way, the trigone is the area where the uterus inserts into the bladder. So, if the tumor is invasive or involves the trigone and the patient is free from metastasis beyond the pelvic area, a radical cystectomy is a treatment of choice. A radical cystectomy involves removal of the bladder, prostate, and seminal vesicles in men. In females, it involves removal of the bladder, uterus, cervix, urethra, and anterior vagina, as well as the ovaries. So it's pretty extensive, guys. After a radical cystectomy, a new way must be created for the urine to leave the body. And the surgical technique to create this is called a urinary diversion. Radiation therapy can be used in combination with a cystectomy or as a primary therapy when the cancer is inoperable or the patient refuses surgery. Chemotherapy drugs and immunotherapy can also be used to treat bladder cancer. The good news is that most bladder cancers are diagnosed at an early stage when the cancer is treatable. Interprofessional care of bladder cancer is going to include surgery, which we already spoke about, radiation, chemotherapy, and something called intravesical therapy. Intravesical therapy is usually started at weekly intervals for 6 to 12 weeks. The drug is instilled directly into the patient's bladder and retained for about 2 hours. The patient's bladder must be empty before installation, and you want to change the patient's position about every 15 minutes during the installation for maximum contact in all areas of the bladder. Maintenance therapy after the initial induction regimen may be beneficial. One of the agents used for intravesical therapy is BCG, stands for Basil-Calmette-Guerin. If it sounds familiar, it's because you talked about this agent during your respiratory lecture. By the way, most patients are going to have irritated voiding symptoms or even hemorrhagic cystitis after intravesical therapy, so just warn them. You want to encourage your patients to increase their daily fluid intake and absolutely to quit smoking. You want to assess the patient for a secondary UTI and stress the need for routine urologic follow-up. Guys, unfortunately, there's a high rate of disease recurrence and progression in bladder cancer, so follow-up studies are extremely important and you want to tell your patient this. Just know and have sympathy that the patient may have fears and serious concerns about their sexual activity or bladder function, and these have to be addressed. So start getting comfortable with having these type of discussions with your patients. Okay, moving on to nephrotic syndrome. So nephrotic syndrome, in simple terms, is basically when the glomerulus that's in the kidney is allowing too much protein to leak out into our urine. And there's different types of proteins that can leak through, but we're going to start with albumin because that's a big one. Do y'all remember what albumin does? What's the role of albumin in our body? Remember, albumin helps regulate the water to stay in the vascular system of our body. Therefore, if we have albumin leaking into our urine, that means we're going to have a decreased level of albumin in our body. And if we have a decreased level of albumin in our body, because it's getting urinated out, then we have nothing to help hold the water in the vascular place. And if we have nothing to help hold the water in the vascular place, this water is going to leak into the interstitial tissue space. This is going to cause the edema that we see manifesting on patients with nephrotic syndrome. You know, it's very common to see +3 edema throughout these patients' bodies because they're lacking that albumin that helps retain the water in the vascular space. And now the water is just leaking in between tissue spaces. Another problem with low albumin level is that in the process of the liver trying to compensate and make more albumin, since we're leaking it out, it creates more cholesterol and triglycerides as it's trying to make more albumin. And this in turn leads to hyperlipidemia, which again is something that we're going to see in the lab values of somebody who has nephrotic syndrome. And remember, glomerulus allows different types of proteins to leak through, not just albumin. Another type of protein that can leak through is our immunoglobulins. And if you remember from the immune lecture, immunoglobulins help us fight infections. Therefore, if we are leaking immunoglobulins, we are also leaking part of our immune protective barriers, which in turn is placing us at risk for infection, right? And then the next big problem is that another type of protein that we're leaking through are the proteins that help prevent the clotting in our body. For example, fibrinogen. If you recall, fibrinogen is a protein that aids in preventing clotting of the blood. Therefore, if we are leaking this out, we are now at greater risk of blood clots developing, right? And if we are at greater risk of blood clots developing, what are we at risk now for? Strokes and DVTs. Nephrotic syndrome. Specific treatment for nephrotic syndrome is going to depend completely on what's causing the nephrotic syndrome. So first we want to try and figure out what's the cause of it and address that primary problem so that the nephrotic syndrome can resolve. However, we do use things like corticosteroids and cyclophosphamide in the treatment of nephrotic syndrome. We also use angiotensin converting enzyme inhibitors or angiotensin receptor blocker drugs to help try and reduce the protein that is being lost in the urine. Of course, if they do have hyperlipidemia, which it's part of what comes with nephrotic syndrome, we're going to include lipid-lowering agents into their drug therapy as well. Diuretics, typically loop diuretics, can also help improve the edema that we're seeing throughout their bodies. And anticoagulant therapy might be needed if thrombosis is present because remember, there are greater risk for blood clots. The patient is naturally going to be placed on a low sodium diet and a moderate protein diet. We're going to want 1 to 2 grams per kilogram per day of protein because again, they're losing a lot of protein, so we need to make up for it in our diet. And it might actually be more than that if their protein loss is too high. So depending on how much protein they're losing depends about how much protein they're placed on in a day. These patients are typically not going to be very hungry. They're going to have some anorexia. So we want to encourage small meals frequently to help meet the nutritional demands that they're going to need. And one of the main nursing interventions for a patient with nephrotic syndrome is basically going to focus on, of course, the management of the edema, right? So you want to manage the edema and also assess if the edema is getting worse or if it's getting better. And you're going to do things like weigh the patient daily. You want to record the I's and O's, right? Very strict with that. And you're going to measure the abdominal girth or extremity size where we're seeing this excessive edema, so that we have this information to be able to compare daily and see if they're improving or if there's no change or maybe they're even worsening. Also remember that these patients are going to be at greater risk for infection, right? So you want to teach them to avoid exposures to people that are sick. Glomerulonephritis is the inflammation of the glomeruli that affects both kidneys equally, and it's actually the third leading cause of end-stage renal disease. The inflammation can extend beyond the glomeruli, and a variety of conditions are associated with glomerulonephritis. These can range anywhere from kidney infections to drugs that are toxic to the kidneys, problems with the immune system, and systemic diseases. It can be an acute, rapid onset that is reversible, or it can be a slower, progressive issue that can result in permanent damage and impaired kidney function. Erectile dysfunction is the inability to attain or maintain an erection that allows satisfactory sexual activity. And it's a condition that's significant because it's prevalent. More than 10 million men in the United States are thought to have erectile dysfunction, and about 50% of all men between the ages of 40 and 70 have at least some degree of erectile dysfunction. And this can come from several different reasons. In the younger men, it's attributed to substance use, drug use, and alcohol, stress and anxiety. Middle-aged men and older is typically due to medical conditions like diabetes and hypertension. A lot of the medications that we give for hypertension, one of the side effects is erectile dysfunction. So sometimes it's due to the medications that we give to treat their medical problems. There's going to be several different tests that are going to be done. We're going to start with a thorough sexual health and psychological history. And there can be other things like, for example, a DRE, digital rectal exam, should be done because we want to assess the prostate size, make sure it's not a prostate issue that's not allowing the circulation, right? Of course, we're going to do assessment of the blood pressure, and especially we're actually going to listen to the femoral arteries as well. You know, is there a bruit? Is there not enough circulation going through? We're going to do complete diagnostic testing on their labs. We want to check for serum glucose, hemoglobin A1C. We want a lipid profile. We want to basically are trying to rule out diabetes. We want to make sure this patient doesn't have diabetes, and that's why they're having erectile dysfunction. We're also going to check their hormonal levels. We're going to check for testosterone, prolactin, LH, and thyroid hormones, because thyroid hormones can be a big cause of erectile dysfunction. We're going to check a PSA level. Remember, PSA levels also check for prostate cancer as well. And we're going to do a CBC. We want to make sure basically, is this a physical problem or a psychological problem? So we run all sorts of tests to try and figure out which one it is. And if it's a physiological problem, what is causing it? We're also going to conduct vascular studies that include penile arteriography. It's basically a penile blood flow study. And we're going to do ultrasounds as well to assess the penile blood inflow and the outflow as well. In regards to interprofessional nursing cares, these patients are typically, especially if it's a physiological problem, they're going to have to be started on medications for it. Erectogenic drugs like Viagra and Cialis. We have a new one that I hadn't heard of. It's called Stendra. These drugs are all PDE5 inhibitors, and basically they work by causing the smooth muscle relaxation, therefore increasing the blood flow into the corpus cavernosum, which in turn promotes the penile erection. They are going to be taken orally before sexual activity. Some of the side effects are headaches, leg pain, dyspepsia, flushing, and nasal congestion. However, there are rare side effects like blurred or blue-green visual problems, sudden hearing loss, and erection lasting more than 4 hours. This is called priapism. So you want to teach the patient to seek medical attention immediately if any of those rare side effects occur. And we've talked about this before in the cardio lecture, but I'll repeat it again. Remember, these drugs may potentiate a hypotensive effect. So you do not want to give them in combination with any nitrates, all right? And we need to teach them that as well, especially they need to relay that information in case they ever need to tell EMS or they're in the hospital. They need to make sure they're forthcoming with that information that they are on erectogenic drugs so that the nurses and the EMS department will know to avoid nitrates. Then there's other things, vacuum erection devices. These are basically suction devices that are applied to a flaccid penis and helps produce an erection by pulling the blood up into the corporeal bodies. Then you have injections that can be given intracavernosomal, like Edex and Caverject. And basically these work by enhancing the blood flow into the penile arteries. Then we have penile implants. And these are going to be implanted into the corporeal bodies to help provide an erection for penetration. And it's basically an inflatable implant. It has little cylinders. However, there's two main complications with this. One of them being infection, the most common, and erosions as well. There may be mechanical failure, but this is a little bit more rare. And of course, these people are going to need some sexual counseling. Men often don't feel comfortable discussing their problems, and they tend to not relay this information. So we do encourage sexual counseling. We don't want those feelings to be repressed. And actually, the partner may need sexual counseling as well. There's several differences in the GU system over pediatric patients. And one of the things to keep in mind with the shorter urethra is that bubble baths are also a big cause of UTIs in little kids. And right now, I know that bath bombs are kind of a big deal with the younglings, so that's something that you want to teach the parents to help prevent UTIs. Do not do bubble baths too often. Do not let them sit in there too long as well. But what I want you to keep in mind is that when a young patient comes in with UTIs, you always want to make sure you can rule out sexual assault as well, because that may be an unfortunate reason as to why they are there. Acute post-streptococcal glomerulonephritis, that's a mouthful, is a common type of acute glomerulonephritis that is most common in children, young adults, and adults over 60 years of age. Develops about 1 to 2 weeks after an infection of the tonsils, pharynx, or skin. For example, streptococcal sore throat or impetigo. And it developed by a nephrotoxic strain of group A beta hemolytic streptococci. It causes fluid retention that occurs because of decreased glomerular filtration. At first, the edema is going to appear in low-pressure tissue, such as those around the eye. Later, it's going to progress to involve the total body, with things such as ascites and peripheral edema in the legs. So, for the edema treatment, you want to encourage sodium and fluid restrictions, as well as rest and antihypertension medications if the blood pressure is too high, as well as diuretics to kind of help flush that fluid out. If the bun and creatinine increases or is off, you may restrict dietary protein. Antibiotics are only prescribed if the streptococcal infection is unresolved. And you want to teach them to do good hygiene. Alright guys, we already talked about nephrotic syndrome a few slides ago. I'm not going to touch too much on it. I just want you to know that this is also that's more common in children than adults, which is why I put it under the pediatric portion as well. And it's the exact same thing that we talked about. It's increased glomerulopermeability that allows too much protein to leak into the urine. And we're going to see the same type of things that we saw, clinical manifestations that we saw with the adults, right? And one of the big flags that you're going to see with the kids is that they're going to be extremely puffy, even in their face. You know, their eyes are going to be hard for them to open. They're going to have edema everywhere. And it's going to be severe edema. And you're also going to see when you draw their labs that they're going to have hyperlipidemia. And that should give you a huge red flag, right? Because a 5-year-old should not have high cholesterol. That's just not normal. They're going to have a lot of the complications that adults have, but some that are more different between children is, for example, peritonitis, cellulitis, and pneumonia. Their care management is going to be pretty much the same. You know, we are going to try out some steroids most likely. We're going to do strict eyes and nose. But you have to think with the child, it may not be very easy to monitor their eyes and nose when it comes to urine, right? Because a 2-year-old may still be wearing diapers. So in that case, you might have to weigh the diapers or weigh the wet pads to be able to get their eyes and nose. Of course, we're going to monitor vital signs, right? Infection is still a problem with these kids because, again, we talked about how immunoglobulins are leaking through the urine. And that's part of our immune defense that we're just throwing away. They're also going to have the loss of appetite that we talked about. And it's going to be a little bit more difficult with children because with an adult, you can kind of negotiate or explain to them, you know, why it's important for them to eat a high protein meal. But you already know how difficult toddlers are to feed. Now imagine a toddler who's not hungry at all. So this is often a huge problem. We're also going to restrict the salt. In some kids, depending on how severe it is, they might have a fluid restriction. So it's going to be a lot for these kids to get used to while they're healing. And these kids are typically not going to be taken care of in the hospital unless there's a huge complication. So there's a lot of teaching that's going to need to be done for the parents, you know. Teach them how to do eyes and nose, teach them about infection prevention, teach them about dietary restrictions. So it's a lot of work on the parents, and it's a lot of teaching that as nurses we have to do, and we have to be aware of what kind of teaching we need to give them as well. Wilms tumor is the most common renal tumor found in children, and a small percentage of these tumors are thought to have a genetic aspect or familial occurrence. This tumor is usually contained within the kidneys, but it can metastasize, and unfortunately, the lungs are a common site for metastasis. There may not actually be any other abnormal findings reported by the parents, except that there's a painless swelling or mass in their children's abdomen. That's the most common presenting sign, a painless swelling or mass within the abdomen that the parents usually discover during routine bathing or dressing of the child. However, the tumor can open if it is overly palpated, so you want to teach the parents, the child, you want to let the nurses know not to do excessive palpation of the abdominal mass. The occurrence of Wilms tumor slightly favors the left kidney, which is actually advantageous because surgically the left kidney is easier to manipulate and remove. Although the tumor may become large, it remains encapsulated for an extended period of time. It's classified as favorable histology and unfavorable histology. Thankfully, about 90% of the tumors fall under favorable, and the survival rates for Wilms tumor are one of the highest among all childhood cancer. Chemotherapy may be used prior to surgery as well as after surgery. It's going to help shrink the tumor before surgery and helps reduce the chance of metastasis after surgery. Radiation therapy is added if the tumors are large or if the prognosis is poor. What are some of the pre-op considerations you need to have? Well, typically surgery is scheduled within 24 to 48 hours of admission. So because of the little time available, you want to keep your explanations simple and you want to repeat them often, with special attention to what the child will experience. You also want to monitor their blood pressure because hypertension from excess renin production is a possibility. Remember the kidneys and renin? We talked about that in first GU day. You also want to have a sign over the bed to not palpate the abdomen because manipulation of the mass may cause dissemination of cancer cells to the adjacent and distant sites. And of course, you want to address their anxiety and their fear. What about post-op? What do you want to watch out for during post-op? The recovery period is usually rapid. However, these children are at risk for intestinal obstruction from the post-surgical adhesion formation. So you want to make sure you monitor the following with them. GI activity, so bowel sounds, stools, vomiting, diarrhea, and of course the usual that you should monitor after any surgery. Signs of infection, INOs, bleeding, blood pressure changes. Let's talk about the assessment of your patient that's going to be geared towards the renal system. What kind of questions do you want to ask during your assessment that, again, are geared towards the renal system, right? Because that's what we're focusing on right now. So you can go ahead and start with the past medical history or comorbidities. Which ones are really important? Hypertension and diabetes, right? Because we know that both of these things can affect the kidneys tremendously. You want to ask about gout, lupus, streptococcal infections, hepatitis. Were they born with congenital anomalies? Do they suffer from renal calculi often? Have they had tuberculosis in the past or a spinal cord or brain injury? All of these things can affect the kidneys. What about medications? We know that numerous drugs are nephrotoxic. Large quantities of NSAIDs and aspirins are terrible for the kidneys. Think about what kind of patients are on large quantity of NSAIDs. So patients like your OA, your RA, that take NSAIDs on a daily basis, right? And of course, numerous antibiotics are nephrotoxic as well. We also know that chronic constipation or drugs that cause constipation can cause an adverse effect on the urinary system. Other drugs such as calcium channel blockers or antidepressants can actually affect the urinary sphincters or the detrusor muscle of the bladder as well, which can then result in nocturia or overflow incontinence. What about the surgical history, the very first bullet point that you see up there? What do you want to ask for that? Any previous pelvic surgeries could be significant regarding that. Also, any pregnancy-related complications that could have affected the urinary system as well. You want to assess their health promotion pattern. You want to watch out for complaints that are vague, like tiredness, appetite changes, weight loss that was not on purpose. Occupational hazards is something you want to inquire about. Do they smoke? Does someone they live with smoke? Is there a family history of any kidney issues, calculi or cancers? And then nutrition-wise, you want to assess their metabolic pattern. So what is their fluid intake like? Do they eat a lot of protein? Maybe they're weightlifters and they're trying to get buff and they're on that meat-only diet. Remember how that was such a big thing a while ago? And regarding their elimination pattern, you want to ask things like, what's the frequency? How often do they go? Do they have nocturia? Maybe they're nurses and they need to hold their urine for 12 hours. Okay, so let's talk about the physical examination items to look out for whenever we're assessing the urinary system. We want to check the skin, right? Are they pale? Do they kind of have a yellow-gray cast? We want to assess the mouth for ammonia breath odor. Something that you read on your textbook, but I didn't mention in the previous slides, is that patients with CKD tend to have an ammonia breath odor. It smells like urine for some reason. And remember how we said that a lot of CKD patients don't know they have CKD right away until it's too late. That might be one of the first signs. And as a nurse, you might be able to pick that up. You want to check if they have any edema anywhere. Are their feet swollen? Are their legs, arms? Because that's a sign of fluid retention. Perhaps the kidneys are not working the way they should be working. You want to check their abdomen, see if you see any enlarged mass from a tumor or whatever. You want to palpate the kidneys, right? To palpate the right kidney, you want to place your left hand behind and support the patient's right side between the rib cage and the iliac crest. Then you elevate the right flank with the left hand. You're going to use your right hand to palpate deeply for the right kidney. The bladder, guys, should not be palpable unless it is distended with urine. If it is distended with urine, it's going to be felt like smooth, round, firm organ, and of course the patient's going to be sensitive to its palpation. Percussion. I know in semester 1 you learned the technique for percussing the flank area, right? It was called the kidney punch. You're going to check for CVA tenderness and pain. If they're there, it could signify kidney infection or polycystic kidney disease. You also want to auscultate. You want to use the diaphragm on the stethoscope to auscultate for bowel sounds, since we already talked about how the bowels can affect the urinary system. So you just want to be very diligent with your physical assessment, because you may be the one person that finds the problem that the patient didn't even know they had. So make sure you learn how to do your physical assessment well. This is something you want to practice during clinicals. And I know right now you may not have much of an opportunity, so at least read this section, memorize it, commit to it, so that whenever the opportunity does come, you know exactly what you're looking for. Okay, everybody, if you have been snacking or eating while listening to this PowerPoint, you might want to stop and put your food away, because there are some graphic pictures and it might gross you out just a little bit. So we know that STIs are infectious diseases, right? And they're spread basically through sexual contact, either with the penis, vagina, anus, mouth, or any body fluids. STIs are actually quite common, unfortunately, and there are nearly about 20 million new STIs that are diagnosed in the United States each year. So even if you're thinking, I don't have to worry about STIs, it's not something that I'm going to work, I'm not going to work in an ambulatory clinic where I'm going to be looking at teenagers. I cannot tell you how many times I have received patients in a trauma unit who have and come in with STIs. So you will encounter it in your field, even if it's not something you're planning on specializing in. So we have noticed that STIs affect certain groups of people disproportionately. For example, people typically under the age of 25, or those who are socially and economically disadvantaged, tend to have a greater risk of STIs and tend to have them more often. And one of the reasons why we think it may happen with people that are economically disadvantaged is because they may not have the money to spend on a condom. It's just as simple as that. And we know that a condom, the male condom, is the best form of protection against STIs. Of course, best form of protection is always going to be abstinence, but after abstinence, a male condom is the most effective thing. So something interesting that you're going to see commonly mentioned in the slides for the next few STIs is that ejaculation is not exactly necessary. So, and I always like to emphasize this, especially to the teenagers, because they think they're really smart by using the pulling out method when they're having sex so that they don't end up pregnant. And they think that also the pulling out method is going to protect them against STIs. And it doesn't, not in a lot of STIs. So it's important to note that ejaculation does not have to occur for them to get some of these infections. Patients with chlamydia are often going to have no symptoms. However, if they do, when it comes to men, the men are typically just going to have some pain with urination and some urethral discharge. Very rarely can they have swelling of the testicles. And if they do have swelling of the testicle, that's because by this point they have an infection of the epididymis. With the females, you're going to have a little bit more different symptoms. You're going to have maybe some mucus with pus of the discharge, bleeding, and one of the main things that we hear with females who have chlamydia is that they have pain with intercourse. Of course, like we mentioned, chlamydia can also be a rectal issue, so they might have some anorectal pain, some pruritus, and mucus-coated stools is a big one as well as painful bowel movements. Chlamydia is something we have a pretty good hold of on how to treat. So if there are complications, they typically arise from the patient simply not being treated, either because they weren't being treated effectively or because they were in denial and never went to the doctor for it. And you're going to see that the complications mostly affect the fertility issue in both male and female. So this tends to come up later on when you have a married couple and they're trying to conceive and they're not able to do so. So they go through treatment, a lot of testing, and lo and behold, there's an STI that was not treated or an STI that became complicated and now they're having fertility issues. When it comes to the drug therapy, it's important to know that we also have to treat their sexual partners, okay? So we're going to have to say, write down all the names and start calling people because they need to be treated as well. And we're also going to teach the patients to abstain from sexual contact for 7 days after the treatment. Unfortunately, with chlamydia, it is a very high rate of recurrence. And it's because of something that we call ping pong effect, where basically, these individuals get treated, but then they go and have sex with someone that has not been treated, and then they get it again. So a lot of people tend to not want to report that they have chlamydia, so they may not, or are even embarrassed to say, how many sexual partners they've had and whatnot. So they may not give out that information, thus causing the other people to not get treated, and in turn having that what we call ping pong effect. Gonorrhea is actually the second most common STI in the United States, at least that we know of, because we know that several things go unreported. And typically women who contract gonorrhea are going to be asymptomatic, or they may have very minor symptoms, but they're often overlooked, so they don't go to the doctor. And that is when, it leads to a little bit more intense symptoms that may have them go to the doctor, such as redness and swelling that can occur at the cervix or even at the urethra as well. Remember, they can also contract rectal gonorrhea. So again, some people think they're quite smart by trying to take a different sexual route to avoid either pregnancy or STIs, and we need to say no, you're still at equal risk of STIs no matter what route you take. Again, like we talked about, women may be asymptomatic, or, as women, they always say that men are the ones that don't like to go to the doctor, but I find that women are the ones that typically don't go to the doctor because they feel like they don't have enough time to go. So typically, since men do seek treatment early, they're less likely to develop serious complications. Females, unfortunately, we don't go to the doctor, they don't get diagnosed, and it can complicate itself and turn into pelvic inflammatory disease. And we know that pelvic inflammatory disease comes with a whole bunch of issues, but one of the main ones is infertility problems. And again, something that can come up later on when the person is trying to become pregnant. for their drug therapy, they're usually going to be on a dual therapy. So the first line of treatment is going to consist of either an IM, which injection of ceftriaxone with an oral dose of azithromycin as a single dose. And however, we have noticed that there's an increasing rate of drug resistance. So some people may need to be retreated later on, especially if they have a positive test 7 days after the first line of treatment. Okay, so let's talk about genital herpes. So the problem with genital herpes is that it stays with this person for the rest of their lives. So they are, from the moment they contract genital herpes, they are now putting at risk every sexual partner that they have from there on. And let's talk about how it comes in. So the virus is going to enter through the mucous membrane or broken skin during contact with the infected person. Then the virus is going to reproduce inside the cell and then continue to spread to the surrounding cells. The problem is the virus is going to enter the peripheral or the autonomic nerve endings, and it's going to ascend, which means go up, to the sensory or the autonomic nerve ganglion near the infection site, and it's just going to sit there and be dormant. When it's dormant, it doesn't do anything. It's basically like it's just sleeping there. However, then we're going to have viral reactivation, or an outbreak is when it's going to happen, when the virus is going to descend to the initial site of infection, either the mucous membrane or the skin. So where the place where that person got infected, that's where you're going to see the outbreak. And the person can have, there's two different types of strands as you read in your book, type 1 and type 2. And an easy way to remember is type 1 above the waist. So this is typically where you're going to see all those outbreaks around the mouth, or what people like to call fever blisters. They're like, oh, it's just a fever blister. No. It's genital herpes. That's what it is. Let's call it what it is, people. So you have to be careful. This is why I do not in any shape, way, or form like family members to kiss my babies on their face or on their lips, because you just don't know what people have, okay? And then type 2, if they have type 2, then they're going to see all their symptoms from the waist down. So you're going to see it in the genital tract, the perineum, and the anus. So the incubation period for genital herpes is anywhere from 2 to 12 days. When they're in the prodromal stage, this is the very beginning, they may not have a lot of symptoms. But once they go into the vesicular stage, that's when they're going to have a few to multiple, often small and painful warts, as well as systemic flu-like symptoms, fever, headache, malaise, myalgia. They might feel like they're coming down with the flu a little bit. And what's interesting is that they're going to feel pain when they're urinating. And the pain is actually coming not from a UTI, but from the fact that the urine, the acid in the urine, is touching the active lesions. And the whole process from the prodrome, which is before they have anything, to when the healing starts to happen, can be up to about 3 weeks. And of course, like we mentioned before, this virus is going to live with them for the rest of their lives. So there are going to be recurrent genital herpes episodes that occur. Usually, though, the recurrent episodes are less severe and they're going to heal more quickly. So if you have a patient that has genital herpes, as a nurse, you want to teach them some of the common triggers of reoccurrence, right? So things like stress, fatigue, sunburn, immunosuppression, even just a period can be enough to set off the virus and activate it again. So genital herpes does have some complications, but they are rare. It's not something that we see very often. So things like blindness, aseptic meningitis, all of these things can happen. So think about the type of patients that will most likely get these type of complications from genital herpes. What kind of patients do you think these will be? Immunosuppressed patients, right? So maybe patients that are on continuous steroids, or maybe chemotherapy, or HIV patients. These are the patients, when they're immunosuppressed, that they are at greater risk for these rare complications that are on your slide listed right there. However, we know that we can have these lesions also kind of spread into the eyes, and that's going to be a complication as well. And of course, speaking of HIV, when you have genital herpes, you have an open sore, and if you have something open, you're risking yourself for another infection, right? And so HIV is a huge risk for these patients, for them to get HIV. Again, another issue with genital herpes is that pregnant women can transmit the virus to the baby. This is also why you're going to see a lot of times the baby comes out and they go ahead and they put those eye drops, on the baby's eyes to help prevent, hopefully, any sort of transmission from it. And because if it does infect the baby, it can affect the skin, eyes, mouth, or even the central nervous system. Although I will say that the doctors have now kind of transgress into this thing where if the mom is having active genital lesions at the time when the birthing is supposed to occur or is happening, they're going to opt for a C-section to kind of prevent the baby from risking the baby from acquiring this. Diagnosis is going to be often based just on the patient's symptoms and then confirmed by the doctor just visually looking at it and doing an examination. There are some blood tests that we can do that will check for antibodies, both for type 1 and type 2, but they're not going to show the location of the infection, and it takes about 12 weeks actually after being contaminated with this virus for the exposure or for these antibodies to show up. So again, it's a virus. We don't have a cure. We just have antiviral drugs that can help shorten the duration of it. And the drugs are very effective. They can shorten its outbreak by up to 80%. It's three main drugs that you're going to see, acyclovir, Farmarin, and Valtrex as well. So our main goal, once the patient has this ASA-NERS, we want to teach the patients to maintain good hygiene, wear loose-fitting cotton undergarments, absolutely avoid sexual contact until the outbreak has completely healed, right? And when it comes to the warts, the main goal is to keep the eruptions clean and dry. We're going to try and do techniques to help reduce the pain with urination. And one of the techniques is, for them to kind of dilute the urine at the same time, which means while they're peeing, they should be pouring some water into the perineal area to kind of avoid that burning sensation. We can also give them local anesthetics such as lidocaine gel and analgesics, and ice packs to the affected area can provide relief for some people. There is such thing as IV acyclovir, but this is reserved for just very life-threatening infections once we're looking at like meningitis and things like that. Otherwise, it's going to be PO oral route. Moving on from genital herpes to genital warts. Just gets better and better, people. So genital warts is caused by HPV. I don't know if you remember, there was a huge kind of movement a few years ago to get all the kids vaccinated with an HPV vaccine that came out, and a lot of parents were not too happy about it. So this is what HPV is, what leads to genital warts. And there's a couple different strands. There's low-risk strains and high-risk strains. The problem is, and the reason why they were advocating for HPV vaccine is because the high-risk strains of HPV can actually lead to cancers of the genital tract, anus, and oropharynx. So they were hoping that by giving this vaccine that they would lower the risk for these children, these adults developing cancer at such an early age. And HPV is transmitted by skin-to-skin contact, and this is most often going to be during vaginal, anal, or oral sex. Again, no route protects you from this STI. And it can be transmitted actually during non-penetrating sexual activity. That's why we said oral sex as well. So the incubation period can range from weeks to months to years. So they may have this and not know about it for years. However, what's interesting is that most people with HPV, remember how we talked about how there was weak or low risk strains? Most people, the virus will clear itself out or just resolve spontaneously after 1 to 2 years. However, the warts themselves can still be visible after treatment. I'm hoping that all the pictures that you're seeing are going to help emphasize the fact to have safe sex. And if you are an older adult and have teenagers in your house, please, by all means, sit them down and let them hear my lectures as well. Put the fear of God in them when it comes to STIs, people. All right, so with genital warts, most people don't know they have the HPV virus because they tend to be asymptomatic. And when it's a female, they tend to get or to be notified of it whenever they go for their Well Woman's exam. Otherwise, they may not even know. With males, you know, they're going to know, of course, if they have the warts that pop up. And besides the warts, there's really no other thing. There may be some itching around the areas as well. So, you know, with complications, we know that warts can grow, spread, and be transmitted to others. But besides that, there's no other real big complications with the low risk strains. With the high risk strains, like we already talked about, this is the problem that it can lead to cancers of the cervix, vagina, vulva, penis, anus, and oropharynx. So that's really the main complications. And of course, there's always going to be a psychological part because the warts are going to, if they have warts, you know, they're going to be visible and they're going to stay there. And the appearance of them may just cause some confidence issues. I can't think of the word right now. Okay, so again, in an attempt to help eradicate some of that HPV strains, there are 3 vaccines that are available, Gardasil being the most famous one. It's probably the one that you've seen commercials for, the one that you heard was being advocated to give to these young girls. It's approved for girls from the age 9 to 26 and boys ages 9 to 15. Again, it's not going to treat if they already have an active HPV infection. So ideally, we want to give these persons the vaccine before they start the sexual activity, which is why they promote it so early for 9-year-olds, which is crazy when you think about it. But it does offer protection against strains causing about 90% of genital warts and about 90% of cervical cancers. So what we're trying really to avoid is these people getting cancer at such a young age and passing from it, right? Because they can even get cancer in their throat as well if they get the virus in there. If they already have the HPV virus, then we're going to focus on treating the anal or genital warts. And the main primary goal of the treatment is basically going to be the removal of the symptomatic warts. And there's going to be different treatments that they can do. They can do removal with laser or electrocautery methods. They can also use, it's something called bichloroacetic acid. And it's basically applied directly to the wart surface and then it kind of comes off. And they can also do something that the patient can just take home and apply it themselves. It's called Condylox. And they apply the gel for about 3 days in a row. And they can do this for up to 4 weeks. And it hoped is that the warts may, you know, go away, fall off. So y'all might have heard of syphilis because of the famous historical figure Al Capone. Y'all know about him? And Al Capone had syphilis, but he never went to the doctor to get it treated. And they did not discover it until it was too late and he was in prison. And by then it had effect at Alcatraz, by the way. By then it had affected him so much that he actually just went ahead and got released from prison in 1939 so that he can live his last days outside. But he had very serious complications with it because it was not treated. So how do you get syphilis? Basically, syphilis is only going to be transmitted when you have direct contact with a syphilitic ulcer or a cancre. And that's what you see on that picture right there. And I know a lot of y'all are wondering, like, why would anybody want to touch that? I mean, guys, the thing is, if it's dark, you're not paying attention, it's very easy for things to go unnoticed. So that is why we always practice what? Safe sex, right? Use a condom, people. So, the problem with syphilis, there's a lot of issues with syphilis, to be honest with you. But what we're worried about is whenever we have a pregnant woman that's infected, because she can transmit syphilis to her baby during the pregnancy, placing that baby at very high risk for a stillbirth, or babies who are going to have complications after birth, like seizures and even death. Syphilis is called the great imitator because it can present with a variety of signs and symptoms that can mimic other diseases. Compared to other STIs, syphilis is going to be harder to recognize. And if it's harder to recognize, it's harder to get an official diagnosis, which in turn is going to delay the treatment. And because of how serious the complications are that are associated with untreated syphilis, the screening programs for high-risk groups are very important. So they're going to treat all sexual contacts from the preceding 90 days. Syphilis comes in stages. The primary stage is going to happen when the canker develops at the site of the transmission, and this can take days to months. However, for the majority of the patients, it takes about 3 weeks. And a canker on the genitals will be noticed, right? But they will go unnoticed if it's inside the mouth, the vagina, or the anus. And if it goes unnoticed, then the patient, and untreated, the patient's going to progress to the secondary stage. And this is where they're going to have the maculopapular rash. After the secondary stage, they move on to the final stage, late syphilis. And this is where the patient is not going to have any obvious symptoms at this stage, but the organism, the syphilis organism, is going to be causing permanent organ damage over many, many years. How do we diagnose syphilis? Through a simple blood test. And once we identify that they have syphilis, then we're going to recommend penicillin G, which is, by the way, good for all stages, primary, secondary, and the final stage. If if they have some sort of contraindication to penicillin, perhaps an allergy, they may look into another alternative. The problem here is that treatment does not reverse the damage that has already been done. So it just basically delays it from turning into later stages, but whatever damage has already been done cannot be reversed. So we want to catch it early. And just like with any other patients with any STIs that present to the clinic, to the hospital, they're all going to be screened for HIV. What is our role as a nurse? Our roles as nurses is that, first of all, we want to assess correctly. We want to do a really good, thorough H&P, history and physical, right? We want to ask them how many partners they have had in the last month or year, and this is not going to be so that we can judge them. This is going to be because it's going to give us an idea of how big of a risk they are in contracting an STI. Somebody who has 2 sexual partners a year versus somebody that has 35 sexual partners a year. Which one do you think is going to be slightly at bigger risk? Very important question to ask is if they have sex with men, women, or both. This is going to give us an idea of what areas to look for, and then also ask them if they use condoms or barrier methods, and then make sure that they are actually using them correctly. Do they know how to put them on the right way? Do they do drugs or alcohol? Because if they do, maybe they're putting themselves in a position where they have sexual intercourse more than they assume, but they can't remember. When asking these questions, make sure that you're going to have a good interprofessional skills, since they are very touchy questions. Do not give away what you're thinking, either by the tone of your voice or your facial expressions. Also, incredibly important to not assume sexual preferences. Ask straightforward questions. Do not ask them in a way that's going to show any judgment. You also want to do a lot of health promotion. Especially if the patient already has an STI, we want to promote trying to stop the spread. So teach them how to do safe sex. I think we need to be realistic. These people are probably not going to stop having sex. So we just need to emphasize safe sex for them. Talk about the correct barriers and how to put it on correctly. Let them know that sexual abstinence is really the only way of avoiding STIs 100%. Make sure to tell them that they want to take special measures before sex. Take time to look at your partner's genitals. Pay attention to any lesions, rashes, blisters, sores. Turn on the lights so you can see everything. All right, and you want to teach everybody, not just the patient that comes in already with an STI, but teenagers, young adults. We want to tell them about the screening programs. Remember, people that are younger than 25 are at big risk for STIs. And psychological support if they already have an STI, because it's going to bring confidence issues. Make sure that they do their follow-ups and that they take their prescribed treatment, and teach them about hygiene measures as well.